Very much. Thank you very much for attending again. And so basically last year, I was also asked to present the same topic, but not to repeat the same thing. This time, I'm going to really concentrate a little bit more, not on the acute part, more for the chronic part, especially area where internal medicine and almost even thrombosis experts, they have sometimes a tough decision to make regarding which patient to extend anticoagulation or not. So we know that VTE is a very dangerous disease, and it's one of the leading causes of death. The death can happen from acute PE, or it can be because of the PE developing CTIF, which cause also death. At the same time, we treat with anticoagulation, which is one of the nightmare medication for most of the physicians because it can really cause death. So always the balance is the way to go. At the same time, if the patient survive VTE, they will go into sometimes complication, which is very, very devastating in the form of CTIF, which is progressive disease and can cause mortality and also poor quality of life. Same for post-thrombotic syndrome. So our management is really to save life, at the same time to prevent complication. Just a quick, we cannot talk about VTE and PE without talking about the importance when we get somebody with PE to look at the severity by doing the PE severity index, because that will tell us the prognosis in 30 days. At the same time, it will affect our management to treat the patient as inpatient or outpatient, early discharge or not, and also the type of anticoagulation initially. We always need to try to prevent even the first VTE, and we know we have a lot of risk factors, either related to the patient or condition. And we try now to really avoid saying provoked and unprovoked. Everybody is really still sticking with the wording, but it's a little bit deceiving. So we really turn to talk about reversible or irreversible, major or minor risk factors. So our goal to try, if it's feasible, to prevent, avoid, reduce, or manage those triggers to prevent the first or the recurrent episode. Unfortunately, many of those patients with VTE, they are at high risk for recurrence. Even like one episode of VTE, especially if there is no major trigger, they are at very high risk for next recurrence. So we should really, and each time they get another recurrence, they are at risk of fatal PE and also worsening the complication we talked about. So effective treatment, meaning really choosing the best anticoagulation for this patient in particular, and the appropriate duration, which, as I mentioned earlier, it's struggling and it's really challenging. So, but by doing this, we can really reduce this and complication. We know, all of us, we start with the initial management, which is 5 to 21 days, depending on the severity and the patient. We go through the primary treatment, this is really the easy part most of the time. At 6 months, this is the time where really the challenge starts. Which patient we need to extend or which patient we need to stop. Unfortunately, in anticoagulation and thrombosis, the guidelines is really weak recommendation. Most of the recommendation, if any, hardly we get level A or 1. So a lot of decision-making needs to be involved in the management. So as we said, we have to balance between the risk of a bleeding and the risk of recurrence if we stop anticoagulation. Most of the time, we forget the patient preference. I think they are the main people who will help us to take the decision. Some patients afraid of the bleeding, some people afraid of having another episode. So we have to give them all the details about the recurrence percentage, bleeding percentage, and they have to help us with the diagnosis, with the treatment. Unfortunately, we don't have a specific score for bleeding risk like in atrial fibrillation, but this is list of condition and medication and so on, which makes the patient at high risk. Low risk meaning there is none of this, which really hardly you're going to see some patient like this. The majority of the patient will be moderate risk, and good number of patients, especially in our facility, SKMC, we deal with very difficult cases, geriatric patient, comorbidities. So most of the patient will towards high risk, especially in particular commitment antiplatelet therapy, cancer patient, patient with bronchiectasis, pulmonary TB with cavitation, and so on, thrombocytopenia also. So again, we have to look at this and make a decision. Many reasons can cause recurrence. I put the most common, really, risk factor for recurrence, which you might not find it in any score, or you don't find it in the recommendation from the guidelines, but there is many studies showing that those are very, very high risk for recurrence. So those should be really looked at when we decide about recurrence. So idiopathic, meaning no trigger, high risk thrombophilia, especially antiphospholipid syndrome and others, proximal DVT, cancer patient, residual thrombus mass, male gender, in particular when they are young, they are at very, very high risk of recurrence, and this should be really looked at carefully. People present with PE without DVT at higher risk to develop another PE, which can kill patients. So those are things needs to be looked at 6 months when we decide to continue or not. The most clear and the most really straightforward guidelines comes from the European Society of Cardiology, where they divided the risk for recurrence into 3 groups. The green one, which is usually low risk of recurrence, less than 3% per year, usually those after trauma, surgery, and so on, and those where we treat for 3 months and we stop. And also the high risk, which is really easy to take a decision on if there is no contraindication for anticoagulation. The high risk, like people who had VTE before 1 or 2 times, antiphospholipid and other thrombophilia condition, and active cancer. The area which really till now, most of the internists, most of the doctors, they are not feeling to go with extension is in between, which is 3 to 8% risk of recurrence. And those we used to say before, many years ago, we consider them as treat for 3 months and stop. But looking at those patients, not every pregnant patient will develop VTE. Not every patient on hormonal replacement or do long fight will have DVT. So there is something else with those patients, puts them at VTE and recurrence for VTE. So this is where the area a little bit tough to take a decision on. But again, the European Society of Cardiology gave really much easier decision for us. For those group, we have the option after looking at the risk of a bleed, looking at the risk of recurrence, talking to the patient, to extend. And most of the experts in thrombosis nowadays, really, they go for extension, especially when the patient, young, male, as we said, some of the other risk we talked about, and also they are low to moderate risk of a bleed. High risk of a bleed is completely different category. So again, here you can see the guidelines saying, like the European Society of Cardiology, patient with antiphospholipid should be on warfarin, not NUAC. In reality, and I think they did it this way to make it clear for most of the physicians, although in reality, only the triple titer antiphospholipid are contraindicated for NUAC. But I think here they put it just to make it clear. But some cases where not easy to use warfarin, it can be considered. The other issue here, you can see level 2A, where patient who does not have trigger, even from the first event. People who has persistent risk factor or minor transient risk factor, again, it's really, you can see the wording should be considered. If we decide, we'll talk about which NUAC to use, because all of them really works very well. If you use apixaban and rivaroxaban after you finish the primary treatment, you can really go to the lower dose with the low risk of recurrence, because the study is done that way. But high-risk patient like active cancer, thrombophilia, and other obese patient and so on, you should really stick with the standard dose. One of the issues we don't do really very well in our practice, after PE, we don't follow up the patient. It's really recommended level A, class A, level B. We have to repeat to see the patient in 3 to 6 months, especially people who are still symptomatic should have echo repeated. And also, if they are symptomatic, VQ scan. If there is persistent defect, we have to look for pulmonary hypertension, CTIF, and treat, because if we treat early, we can save the patient. Otherwise, it's too late. But the time does not allow. There is people who is asymptomatic at 3 and 6 months. Still, we have to do echo and follow up for those high risk, but the time doesn't allow us. The 2016 ACCP, again, almost in the same guidelines. So for the sake of the time, I will skip it. And actually, the European Society of Cardiology is much clearer and straightforward, especially for the extension anticoagulation. So NOAC now is the standard of care, and we have a lot of NOAC. This is meta-analysis looking at all of them. So you can see they are at least as effective as warfarin, but sometimes numerically a little bit better. From safety issue, overall major bleeding, again, it's much more safer regarding major bleeding than warfarin. That's the reason now, if there is no other reason not to use it, it's the standard of care. And also, especially for the fatal bleeding and the intracranial bleeding, which is really scary and devastating, it's much less with NOAC. So that's the reason, again, it's a standard of care. And this applies to also for the high risk of patient. We're talking about elderly patient, fragile patient, people with CKD. Still, NOAC is better than warfarin. So we have multiple NOAC. So which one to start, to choose? So this is what I do with the resident, with the patient, with everybody. I think we have excellent NOAC, all standard. All of them work very well. Safety issue, some people say one is safer than the other, but I think we really need to be careful with this messaging, because there is no direct study to compare NOAC. Even real world, there is conflicting messages, and real world, we know there is a lot of bias in it. So all of them work very well. All of them, if the patient is going to bleed, will bleed. You know, using lower dose does not prevent bleeding, but actually we're not giving good protection. So those are the things we really need to be careful. So you can see we have, you know, the most 4 NOAC. 2 of them per study, we have to use low molecular heparin for 5 days, then we can go to them. But I will show you at the end of the presentation regarding edoxaban, there is update where you can use it without. And you can see on the right side, those are the things I will discuss with the patient. Once a day versus twice a day, with food, without food. So if you give rivaroxaban, needs to be with food, with the fattiest meal. If you decide to give apixaban, be sure to talk to the patient and be sure they will take it twice a day. Otherwise, you're not protecting. Drug-drug interaction, we'll talk about, especially when we talk about cancer, VTE. It's very important. Also, reduce dose. I will give edoxaban this point, because basically it's the only NOAC where they have in their study reduced dose. Otherwise, it was just more pharmacokinetics and so on. Severity of VTE will decide, should we go with heparin initially or NOAC right away, and we'll talk about it a little bit. So renal function, creatinine clearance, liver insufficiency, all of this needs to be looked at. So then take a decision about which one to use. So for PE, as we said, we have to do the severity index. We need to look at RV dysfunction. We have to do troponin and BMP, because then if the patient is in intermediate risk, those patient needs to be hospitalized, needs to be started on heparin initially, then you will go to NOAC. In some cases, like in PE, although in our practice, all PE get admitted, but you can discharge them early if they are at low risk. So that's the reason sometimes using heparin is very important when we deal with extensive VTE or severe PE. And also, there is many people, they look at anti-inflammatory effect of the heparin, the vasodilation, and so on as extra benefit. So giving 5 days of heparin, which some people, they see it as obstacle for some NOAC, in reality it's not, and we've been doing it with warfarin for many, many years. Since the sponsor is edoxaban, so just I will talk about the study. As we said, all of them are very good medication. All of them, they have different profile where you can choose on. The Hoxi VTE, it was really large study. The patient was really stratified for different criteria, especially the important ones, the dose reduction and the severity of the VTE. So the dose reduction when creatinine 30 to 50, weight less than 60, or there is commitment PGP inhibitor, then you give the 30 milligram instead of 60, and this is really depending on the patient. So this is dynamic one, which we see in our practice. Some people might be on the medication for a while, then they are off, so usually we should adjust the medication accordingly. So the things with the study of Hoxi, they really used very extensive DVT and very high-risk patient with right ventricle dysfunction. So that's the reason the study design was with heparin. So they didn't have choice without it. The study showed from efficacy, it's non-inferior to heparin and warfarin, but from safety, it was much less major bleed with edoxaban comparing with warfarin. And you can see here, I put for the age because many people are afraid with the increased age. So it's the same issue, efficacy and safety for above 75. If you look at other subgroup, it's exactly the same. With the reduced dose, there is the efficacy and safety. Weight less than 60, more than 60, more than 100, less than 100, creatinine clearance. So all of them showed really the benefit. In particular, as we said, people with extensive DVT and severe PE, which reflected by high BMP, they did actually much better with the edoxaban if we took them as subgroup. Reduced dose, again, it showed the efficacy and also actually showed less bleeding. And it's the only one who studied in a randomized control study. For cancer, basically, I will skip a few slides just because of the time. We know that it's very high-risk patients. Cancer can cause VTE, can cause especially asymptomatic VTE. So this is one thing we really should say. Any patient come with vague symptoms, with cancer, think about VTE, especially intra-abdomen. Of course, if the patient comes with recurrent upper arm, bilateral, you have to really look for malignancy from the beginning. Otherwise, not everybody should really get pan-CT, depending on the history, the family history, and so on. But this is something I see everybody will get pan-CT. It's not really right. But elderly with suspicion, yes. PE in cancer is the second cause of death with infection after progression. The minute we give cancer to a patient, the VTE risk is fourfold. Then it fluctuates up and down depending on surgery, hospital, catheterization, metastases, and so on. Again, there are a specific risk factor which makes those patients at high one. So I will skip here. Again, for the Hoxi VTE cancer, we showed that the efficacy is there. So you can see actually edoxaban was better than low molecular heparin, but the bleeding was a little bit more, and most of the bleeding coming from the GI upper area. And if you look at GI cancer versus non-GI cancer, basically it was the GI cancer. So that's the reason we try to avoid it if possible. And the severity with edoxaban was even less than the low molecular heparin, even in the major bleeding. So I will skip this one. Okay, so the guidelines now, even with cancer, non-GI cancer, it's recommended to really go ahead with NUAC as a first line. The other issue I wanted to, but for the sake of time, just 1 minute, there was a study regarding distal VTE with cancer with edoxaban up to 12 months, which really showed better than 3 months. And this is one of the longest study to show it. And also the newest trial presented in September in the European Society of Cardiology, looking at using edoxaban without the 5 days of enoxaparin, which is already used for a really good number of patients in Japan, and it was similar if you use or not. But the advice is still for severe patients, better to go with the heparin first, then you can go without it. Thank you.